Hi, everyone. Um, to whoever's watching this, thank you for listening today. Today, I'll be presenting on my doctoral capstone project, which focuses on improving student preparedness for level two fieldwork and hand therapy, an area where many OT students report feeling underprepared. The research question, I'll move this out of the way a bit, is what asynchronous rehabilitation topics and methods will most effectively prepare OT doctorate students for level two fieldwork and upper extremity rehabilitation? So, hand therapy is a high specialized and fast-paced clinical setting. Students often struggle to meet expectations due to limited exposure in traditional OT curricula. So, fieldwork educators report that many students enter without a solid foundation in anatomy, manual therapy techniques, or clinical reasoning. To address these gaps, I explored the use of gamification, which applies game-based elements like quizzes, feedback loops, and scenario challenges to non-game settings. So, as a strategy to increase engagement, motivation, and skill development. In terms of process of experience, my process began with a literature review to better understand how gamification has been used in clinical education and how it might support OT student preparedness. Then I conducted a needs assessment using surveys. So I collecting feedback from two groups, former OT students who have completed hand therapy fieldwork and also fieldwork educators who've supervised them or students in general. This gave me a clearer picture of what's kind of expected in the clinic versus what students actually know coming into their level two fieldwork rotations. I analyzed the survey responses and found several recurring gaps. So, in clinical reasoning, documentation, anatomy, and confidence managing common diagnoses, educators really emphasize the importance of professionalism, self-direction, and foundational knowledge coming into level two fieldwork. From this, I designed a set of remote asynchronous preparatory group of modules or a course based on the feedback and best practices in instructional design. The module was then kind of like pilot tested with faculty who provided me feedback that helped me refine the format, the interactivity of it, and also the clarity and content that's being presented. Here in the center, reading from the results section, from that survey that I distributed, focusing on the student feedback, 66.7% of students reported feeling somewhat unprepared for hand therapy fieldwork. So coming into that fieldwork rotation, I mean, it can be daunting. It's a fast-paced experience from my own personal experience. And while in our traditional OT curricula, we do touch base on some upper extremity rehab and conditions, it's not super in depth to the point where you would feel ready to kind of just jump in within the first like 2 weeks of the rotation. It just feels like it's a bunch of new foreign knowledge that's being like exposed to you all at once. Students also reported feeling most comfortable with basic anatomy in general and also conditions such as carpal tunnel syndrome and lateral epicondylitis. Some of those more common diagnoses in comparison to like, let's say, Dequervain's tenosynovitis, or even like flexor tendon injuries. While we still learn about these things in school, it's not as in-depth as others where we might feel more comfortable in jumping in when it comes to being a level two student, just kind of diving in. Students found it difficult to learn and retain provocative testing, nerve anatomy, and differential diagnosis skills. Those are things that might be not too heavily emphasized within regular and traditional curricula, and it can be a bit challenging, and it feels like it's very, very useful information to have when you are a level two student in the clinic. And then students also express desire for more applied preparation or clinical work to kind of tie that piece of bridge between academics in the classroom and then also applying it to an actual person who's sitting in front of you. In terms of feedback, the educators reported challenges mentoring students due to time constraints and managing caseloads. And from my experience, I mean, it's a fast-paced environment and it's difficult for a CI to give everything that you need. There's got to be some sort of independent study there because they're not only helping you guide through and bridging that gap between academics in the school and the specialty setting, but also managing their own caseload as well. Educators noted students focus on technique rather than clinical reasoning and lack of extensive knowledge. So, kind of looking for the shortcuts there, like what tests or perhaps maybe even unfortunately cookie cutter methods might be used in certain conditions to kind of get you through rather than understanding from like a foundational or anatomical perspective what is going on with this patient in terms of their condition, what is their symptomology, and then based on that and their functional deficits, what can we do as OTs to help them reach their goals and like work their way around those deficits. So kind of really understanding that foundational knowledge and that you might want to skip over in this like time of like education really because we go over it in undergrad like in anatomy and stuff when we get touch on it in postgrad, but it still can slip away. And so really understanding the roots and the foundations can be very, very critical and very, very useful. Educators also expect foundational knowledge in upper extremity anatomy, just the bare minimum foundational musculoskeletal neural, and then understanding standardized assessments that are appropriate and relevant to upper extremity rehab, physical agent modalities, and then even splinting basics. Um, while we do get some experience in a lot of these in school, again, applying it to an individual who's across from you and having more practice is something that can be useful. So, for example, for us in our PAMS, we had in our PAMS module or week, however you want to approach it or call it, we focused on it for about a week. Same with splinting. And so, while we might feel comfortable at the end of the classroom day, once it comes to level two, which can be months, if not maybe a year later down the road, it might still feel a bit foreign. And then lastly, regardless of all this, educators still believe that students can be successful despite the knowledge gaps as long as they engage in independent study and and applying their critical thinking. So it's going to require some extra work and kind of understanding that when you're going into a level two fieldwork rotation in hand therapy, understanding that the demands are going to be a little bit more increased in terms of independent study and feeling that you need to prepare and fill in those gaps so that when it comes to you showing up to the clinic, you feel prepared and ready and don't feel that that stuff is too foreign. To briefly highlight the module itself, it covers upper extremity anatomy, so skeletal, muscular, and neurological systems. Also, clinical skills like goniometry, physical agent modalities, and common hand diagnoses. The learning experience includes different like interactive lectures, quizzes, and case studies with those gamified elements to support engagement and retention. I also used a bit of a scaffolding approach, meaning that the module starts with foundational content and then gradually builds up to more complex clinical reasoning, helping students progress without necessarily feeling too overwhelmed. A very important piece of feedback that I received from a clinical educator who reflected on their experience of going into a level two in hand therapy when they were in grad school was that the university gave them a resource that was honestly enough to prepare anyone for the CHT exam. And so, as a level two student, that might just be too much and it was very overwhelming for them. And so, my goal here, my means was to provide foundational and entry level information to sort of get the ball rolling for students going in a level two, not necessarily to be ready to take on a full caseload off week one or two, but more so give them an idea of common diagnoses that you might be treating, reassure and bring up these topics that may have been already brought up in their undergrad or postgrad and sort of just kind of solidify their knowledge and comfort levels with the material and different like ideas of what you might be doing for treatment or evaluations to sort of again get that ball rolling, make them feel more comfortable and prepare them to perhaps maybe even transition into taking on more patients at a faster rate than they would have if they didn't take this course or set of modules. And so for the discussion section, moving up to the top right corner here, the project hopefully will show that a student-informed, needs-based educational resource can help close the preparedness gap for OT students entering specialized clinical settings, as this set of modules and course is not necessarily live quite yet. It will be for students who are coming into their level two fieldwork rotations in the following year, and that's when I can take in feedback and assess whether or not this was meeting the objectives that I was hoping to, but I can get into that a little bit more. But a few key takeaways is that clinical reasoning, anatomy knowledge, and condition familiarity were the top gaps that were identified. And so that fueled the pace and the set of information that I had provided for my group of modules in the Moodle page. Also, gamified asynchronous content increases accessibility, supports engagement, and allows students to learn at their own pace as I read through relevant like medical research material for students. And then tools like SOAP note writing and real world case studies can support the development of practical skills as well. And then lastly, collaborating with fieldwork educators really ensures that the content stays relevant and actual to clinical demands. And then also even instructors can also benefit as the modules can kind of reduce the onboarding time to allow students to arrive better prepared for success, especially in this specialty setting. But here, looking at the implications for future directions, I got to categorize in three categories for students, educators, and overall quality improvement. But for students, it can enhance the preparedness of the students in general and perhaps even new clinicians. So I could even take these set of modules and perhaps I'm working at a clinic who is taking on a new therapist who has no experience in hand therapy. They might be at similar kind of on par pace as a student in level two transitioning into level two fieldwork setting in hand therapy can kind of help you get some foundational knowledge before you start getting into those rabbit holes, perhaps like getting deep into like perhaps carpal row theory or deep into like TFCC treatment. But it can also support the integration of clinical and academic learning in specialty settings to begin with, kind of setting a skeletal system almost in a way, or a scaffolding for different specialties, perhaps maybe like pediatrics or even perhaps even like pelvic floor therapy, kind of use these kind of techniques and interactive gamified components to sort of bridge those gaps that are found. In terms of educators, fieldwork preparation tool here in general can bridge the gap between the traditional curricula and the practice. Again, as I mentioned, between level two student, building that gap between transitioning from taking all these courses and then going into a specialty setting where perhaps you might not feel too comfortable. It could also help support educators setting clear expectations and provide early exposure to upper extremity rehab competencies. This could be used for students who are perhaps maybe not going to have a level two field rotation or they're thinking about it. They can still take these courses and see whether or not it's something they might want to pursue in the future or even might put it top of their list when it comes to getting placed to the different sites. And then lastly, in terms of quality improvement, um, I can conduct formal evaluations at the end to measure the module's effectiveness, and then also incorporate that user feedback for ongoing content refinement, and then update content based on current literature as that stays ever changing. Lastly, I want to mention is just some theoretical foundations that I used for this entire process. So again, mentioned gamification and education was probably one of the bigger ones. So kind of supporting the learning by increasing engagement, feedback, and motivation. And so, as I said, studies in medical education have shown that it can lead to better attention, increased autonomy, and more active participation. And these game elements kind of helped transform passive content into more of a dynamic experience in a way. Self-determination theory kind of highlights the importance of autonomy, competence, and relatedness. And so gamification supports all three by offering students choice, the challenge, and feedback, which fosters intrinsic motivation and confidence as they prepare for their fieldwork. But all in all, in summary, this project kind of created a practical, flexible tool to bridge the gap between classroom learning and clinical expectations within a hand therapy setting. And so the combination of evidence-based design, real-world feedback, and theory-informed strategies kind of make it a valuable resource for both students, myself, educators in general. And I do really hope that in the future this can be useful for others, as in the end, it was very useful for myself as I prepared to transition from a student into a practitioner, hoping to work in a hand therapy setting. But all in all, thank you again for your time. I really appreciate it, and I hope you are all well.